B cells and autoantibodies in the pathophysiology and treatment of Pemphigus vulgaris. Pemphigus vulgaris is a B cell-mediated autoimmune disease characterized by the production of pathogenic autoantibodies directed against desmoglians, proteins responsible for cell adhesion in the epidermal layer of the skin. These autoantibodies cause loss of cell adhesion in the skin and mucous membranes. The etiology is unknown, but B cell activation and differentiation give rise to autoantibody-producing memory B cells and plasma cells. Autoantibodies in Pemphigus vulgaris target desmoglian 3 and desmoglian 1 that function in desmosomes in the suprabasilar keratinocytes in the skin and mucous membranes. What's unique about Pemphigus, in comparison to several other autoimmune conditions, is the antibodies are thought not to be just a marker of the disease, but actually to cause the disease without needing complement activation. Two mechanisms are thought to be responsible. The first is steric hindrance, where the binding of the antibodies disrupt the adhesion between keratinocytes so they fall apart. And the second is through an intracellular cascade of events which cause the cytoskeleton within the keratinocyte to break down so that the cells shrink and pull apart from each other. The disruption of cellular adhesion results in acantholysis and characteristic blister formation. These blisters are flaccid and rupture easily, leaving behind painful erosions. A positive Nikolsky sign, where blisters rupture easily with mild lateral pressure, is suggestive of Pemphigus vulgaris and an indication for biopsy. Pemphigus vulgaris most frequently presents in the mouth, but may also involve other mucosal surfaces as well as the skin. Histologic and serologic testing are necessary to confirm the diagnosis of Pemphigus vulgaris. Although a positive Nikolsky sign is indicative of Pemphigus vulgaris, additional testing is needed. Histology using H&E staining is the first test to definitively diagnose Pemphigus vulgaris. This is done with a biopsy of perilesional tissue or of a small intact vesicle present less than 48 hours. H&E staining shows characteristic acantholysis from disruption of the cellular adhesions. Serologic testing is used to show the presence of anti-desmoglian antibodies. This is done with either immunofluorescence staining or ELISA. Direct immunofluorescence is used to show the presence of autoantibodies in a biopsy of perilesional tissue. Fluorescently labeled antibodies tag the pathologic anti-desmoglian antibodies, showing the presence of IgG and C3 in a net-like pattern within the lower epidermis. Anti-desmoglian antibodies in the blood can also be assessed by indirect immunofluorescence or ELISA. For indirect immunofluorescence, serum is incubated in a tissue substrate. Anti-desmoglian antibodies, if present, will bind to the tissue substrate and can be tagged by a fluorescent marker. ELISA is a serologic test to measure specific anti-desmoglian antibodies in blood serum. Anti-desmoglians, if present, bind to substrate in a well and are tagged by a colorimetric marker so that the titer can be measured. The high sensitivity and specificity and increased availability of these tests has increased their utilization. In addition, serologic testing can also be helpful monitoring the response to therapy. Once the diagnosis of Pemphigus vulgaris has been confirmed, assessing disease severity helps determine therapy. There are currently no accepted cutoff values to define disease severity. It can be mild, moderate, or severe. There are two scoring assessments used in clinical trials. These factor both the extent of involved area and lesion quality. The goals of therapy are to promote healing of blisters and erosions, improve functional status, reduce the development of new blisters and erosions, improve the quality of life, and limit common side effects associated with long-term immunosuppressive or corticosteroid therapy. Corticosteroids are the backbone of the Pemphigus vulgaris therapy. Corticosteroids quickly suppress inflammation, reducing B cell levels, and autoantibody titers. Patients with early, mild, and/or orally limited disease may be successfully managed with topical steroids. Those with more extensive involvement will require systemic immunosuppressive therapy in addition to corticosteroids. Corticosteroids have improved overall mortality from 75% before the advent of corticosteroids to the current less than 30%. Most of the current morbidity and mortality relates to the adverse effects of therapy. particularly infections and cardiovascular disease. The side effects of corticosteroids depend on the length of usage. Because of these steroid side effects, corticosteroids are tapered once the patient has responded, meaning existing lesions have begun to heal and no new lesions have developed. The objective should be to achieve as rapid a remission as possible, as few flares as possible, and minimal morbidity associated with treatment agents. Complete remission on therapy is defined as the absence of new or established lesions for at least 2 months while the patient is receiving minimal therapy. Steroid-sparing agents are recommended in Pemphigus vulgaris. Rituximab is an anti-CD20 monoclonal antibody that has been FDA approved as the first targeted immunosuppressive therapy for Pemphigus vulgaris. CD20 is present on B cells, including mature, naive, and memory B cells, but not on differentiated plasma cells. Rituximab causes a selective, transient depletion of CD20 positive B cells, thereby reducing autoantibody titers in Pemphigus. Because plasma cells do not carry the CD20 marker, not all antibody production is suppressed, meaning serum antimicrobial IgG titers remain stable. It has been hypothesized that short-lived plasma cells are responsible for producing the bulk of pathogenic autoantibodies responsible for disease in Pemphigus. Clinical trials of rituximab, administered with corticosteroids, to patients with Pemphigus vulgaris have demonstrated greater efficacy compared with steroids alone or steroids plus mycophenolate. In the RETUX-3 trial, patients with newly diagnosed Pemphigus were randomized to receive either oral prednisone alone, tapered over 12 or 18 months, or rituximab on days 0 and 14, 12 and 18 months, combined with short-term prednisone tapered over 3 or 6 months. The primary endpoint was rate of remission off therapy at 24 months. At month 24, 41 of 46, or 89% of patients randomized to rituximab plus short-term prednisone, were in complete remission off therapy, compared to only 15 of 44, or 34% assigned to the prednisone-only group. Rituximab is more than 2.5 times more likely to result in remission, with the number needed to treat less than 2. Patients receiving rituximab achieved complete remission off therapy significantly faster than those receiving prednisone alone. Those in the rituximab group had a significantly longer time in remission. The relapse rate for patients receiving rituximab was less than those receiving prednisone, and 75% of patients receiving rituximab achieved 2-year disease-free survival, compared with only 37% of patients receiving prednisone alone. Additionally, in the 3rd year of follow-up, of the patients who achieved complete remission off therapy at 24 months, only 1 patient representing 2% of the rituximab group experienced a relapse in year 3, compared with 4 of 15 patients, or 27% in the prednisone group, who experienced relapse in year 3. Total and desmoglein-specific B cells were eliminated by rituximab, but numbers remained unchanged in the prednisone group. Anti-desmoglein antibody titers decreased similarly for both groups in the first 12 months, but rebounded to detectable levels at 24 months only for the group receiving prednisone alone. A second endpoint was the difference in cumulative steroid dose. Patients receiving rituximab used nearly 1/3 of the amount compared with the prednisone group, and patients receiving rituximab had greater improvements in quality of life scores than those receiving prednisone alone. More patients discontinued the study from the prednisone alone group due to treatment failure and treatment-related adverse events. Similarly, severe adverse events were about twice as common among those receiving prednisone alone than those receiving rituximab. The most common serious adverse events were diabetes and endocrine disorders, myopathy and bone disorders. The infection rates were similar among both groups. The RETUX-3 trial demonstrated the safety and efficacy of including rituximab in first-line therapy for Pemphigus for bringing about complete remission and allowing for a more rapid steroid taper than the standard of care. Another recent randomized controlled trial, Pemphigus, compared the use of rituximab with the steroid-sparing agent mycophenolate mofetil. In Pemphigus, rituximab and mycophenolate were both used in combination with prednisone, and a short-term steroid taper in patients with a new diagnosis of Pemphigus vulgaris to assess for complete remission and disease-free survival over 52 weeks of treatment. 135 patients were randomized, 67 to Rituximab, and 68 to mycophenolate. 40% of patients receiving Rituximab achieved sustained, complete remission off therapy at 52 weeks, which was superior to the 9.5% of patients receiving mycophenolate. Patients receiving Rituximab had a significantly lower cumulative steroid dose, as well as a lower median daily dose. Rituximab was associated with significantly fewer disease flares and fewer patients experiencing disease flare. Patients in the Rituximab arm were nearly 5 times more likely to achieve sustained complete remission off therapy, and about 7 times less likely to experience a flare compared with those in the mycophenolate arm. Rituximab was associated with significantly greater improvements in the DLQI compared with mycophenolate. Rituximab was associated with a numerically greater infection rate and rate of infusion reactions. Corticosteroid adverse events were similar for both the Rituximab and mycophenolate group, but numerically higher for the mycophenolate group. The Pemphigus study establishes the superiority of Rituximab over mycophenolate in the treatment of Pemphigus vulgaris. Other agents, such as azathioprine, mycophenolate, cyclophosphamide, and IVIG, can be used to suppress the immune system in Pemphigus vulgaris. Azathioprine has steroid-sparing effects and can be used in combination with prednisone for control in early disease or as maintenance therapy. Mycophenolate can be combined with prednisone for treating early disease, or can be used after initial treatment for Pemphigus vulgaris. Cyclophosphamide is generally reserved for patients who do not respond to other immunosuppressives for Pemphigus, due to the side effect profile associated with cyclophosphamide. Measures to reduce high titers of anti-desmoglein antibodies include IVIG immunoabsorption, plasmapheresis, and plasma exchange. These have been described as effective in severe Pemphigus vulgaris patients for controlling disease activity by reducing serum levels of autoantibodies. But these are not immunosuppressive. The primary objective of the therapeutic management of Pemphigus vulgaris is initially to control the disease, heal the bullous skin and mucosal lesions, and minimize the associated functional impairment. In addition to immunosuppressive therapy, wound care and oral hygiene measures are important to relieve pain, reduce infection, and foster healing of Pemphigus vulgaris lesions. In the case of relapsed Pemphigus vulgaris, options include increasing or restarting steroids, adding an immunosuppressant, or replacing the first-line immunosuppressant with another if already on combination therapy. The weight-based lymphoma dosing protocol for Rituximab may be beneficial for relapsed or resistant disease. Subsequently, the real challenge is to prevent relapses and reduce adverse events associated with the prolonged use of steroids and immunosuppressive agents. This requires close clinical monitoring of patients over long-term therapy. In summary, Pemphigus vulgaris is an autoantibody-mediated condition that responds well to immunosuppressive therapy, particularly when detected and treated early. Currently, B-cell depletion with Rituximab combined with corticosteroid therapy has demonstrated the greatest efficacy for inducing remission. Steroid-sparing agents are necessary to induce and maintain remission, and to reduce the adverse effects associated with long-term corticosteroid therapy. For discussion of the practical applications of immunosuppressive therapy in Pemphigus vulgaris, continue to the case discussions.